Hello. You're listening to Resilience Radio. I'm Irvin Eisenberg, host of the show and owner of Resilience Occupational Therapy. As usual, the opinions on this show are not necessarily shared by me. I like to feature a variety of different approaches, and nothing is meant to be medically diagnostic or prescriptive in any way. Today's guest is Eric Jacobson. He's a PhD teaching at Harvard and is also a Rolfer who studied with Ida Rolf. It's great to have you on, Eric.
Yeah, I'm glad to be on, Erving.
Can you start us off with a little bit of your journey, what brought you to do what you're doing and what that path has looked like?
See, I was basically sort of a socially anxious, kind of depressed person, but I was a high achiever academically and athletically. So eventually I fell out of the academic system. I got kicked out of college because I was doing anti-Vietnam War and psychedelic drugs and not that much studying. And then I was sort of a hippie in Delaware doing very boring jobs like lumberyard and liquor store checkout. And I realized one day I was starting to resent anybody that had an interesting life. I said, whoa, I don't want to become one of those people. So I had relatives in Boston. So I said, well, that would probably be more interesting than Delaware. So I moved to Boston. Oh, and I had gotten into, in those days, the 70s, there were drug abuse counseling centers that were run by hippies because it was assumed that hippies could talk to hippies or something like that. So I was running one of those. And so we had people come train us to do encounter groups and things like that. So when I moved to Boston, there was a place in Concord called Associates for Human Resources. It was run by graduates of Boston University, what was the name of that program? Human Potential Program. And where they were teaching people to do T groups, which is a very early form of encounter group. And so those people started a center where they invited people to come and demonstrate new therapies. So I got exposed to a lot of new stuff. And they invited Will Schutz to come and demonstrate Rolfing. It was very interesting because you could see the person's body change right away. So that was attractive to me. And so I and one of my buddies, Paul Jacobs, I think he's still practicing in the Boulder area, went to Florida to get trained in Rolfing and met Dr. Rolf. And that was how it all started.
And what appealed to you beyond the initial seeing of bodies changing? What appealed to you to sort of to continue with that training?
I thought of it, I was very interested in Gestalt Therapy too, and I had some training in Gestalt Therapy, and I thought I'd combine the two. This did not sit very well with Dr. Rolf when I mentioned it. Her response was, "We are not an adjunctive therapy, Mr. Jacobson." And the only way that I was accepted was that Paul Jacobs talked to her and said I was really a good guy.
I love the people who've studied with Ida. Each person has I feel like she treated each of her students just a little bit differently, but always with quite a bit of her personality.
Yeah, well, she was a triple Taurus New Yorker, so she was pretty adamant about her point of view. So that's how it started. And for a long time, I did Rolfing and Gestalt Therapy, not simultaneously, but sometimes Rolfing, sometimes Gestalt Therapy. Did that for about 12 years. I was very surprised. I expected her to be good at Rolfing, but I was very surprised at how intellectually substantial she was. Her lectures are very interesting. And then my basic training was in Florida. Well, the first half of my basic training was in Florida. The second half was in Big Sur at Esalen. And she was simultaneously teaching an advanced course at Esalen. So we all went to the same lecture in the morning, then we divided for separate classes. And the basic class at Esalen was taught by her son, Richard Demerly.
Okay. And it seems like you've done more than just Rolfing with your academic career. Can you speak to how those overlapped?
After about 12 years, doing psychotherapy and doing Rolfing are both very interesting, but you're in a little room with one other person. And after 12 years, I started to feel sort of claustrophobic about that. I said, well, there's a much bigger world. Maybe that would be interesting too. And I had met some Tibetan lamas. Chogyam Trungpa was the first Tibetan lama to start a center in the US, I think, actually in central Vermont, Barnet. And so I used to go up there to listen to his lectures. He had been educated at Oxford, so he was the first lama that I know that not only had very fluent English, but understood how Westerners thought. So his lectures were very interesting, and I became intellectually convinced that he was right, and that Buddhism's point of view was the right point of view. And he taught just sitting with the breath. So I was doing that. And he had a center in Cambridge, too, that had weekly practices. And then one day on their bulletin board was a poster, well, just an 8.5, 11 sheet of paper, announcing there were some lamas in Western Massachusetts. So my friend Matthew and I drove out there. I won't tell you the whole story, but it was quite interesting. Chogyam Trungpa was doing his best to make this understandable to Westerners. And the lamas out in Western Massachusetts were in full robes. They didn't speak much English, and they weren't trying to psychologize the thing at all. Trungpa's strength was could make it psychological. But they were doing straight Buddhism, and they were doing a lot of chanting and ritual. And my friend and I were really blown away by the chanting we did with them. And so we went back the next weekend and said, hey, can we be your students? And they said, oh, yes, yes, yes. So that was the start of a long relationship with those two lamas. And I guess when I started to get really bored about being in a little office all day, I said, well, it would really be cool to be an anthropologist and study the Tibetans. And I think I should have just gone and studied the Tibetans, but I decided, no, I should be an anthropologist. And so I couldn't get straight into the anthro program at Harvard, but I got into the education program. And there was a professor who had a joint appointment. I could remember his name in a minute, Robert Levine. And he engineered me transferring sideways into the anthro department. So then I was in a department that had a program in medical anthropology, very strong NIH-funded program in medical anthropology. And I got a pre-doctoral grant, and then I got a doctoral grant to study Tibetan medicine, psychiatric aspects. So I made several trips to India. I couldn't stay there year round because there's a thing called the monsoon where it rains literally 95% of the time, day and night. And I just got sick. People who are born and raised there get sick because everything's wet. You're never dry. Your sheets are damp. Your clothes are damp. So I would go in the non-monsoon part of the year and got involved in studying. And my teacher, the teacher I had met in Western Massachusetts, had a monastery in Sikkim, which is in a province in far northern India. And I ended up doing my anthro research in Darjeeling, which is only about a 2-hour bus ride away. So I could spend time in both places. So then I would go back to Boston and Rolf when I would run out of money. So I did that for 4 or 5 or 6 years. And then eventually the department said, you have to either finish your dissertation or we're kicking you out. You've been in the program too long.
You were mostly interested in doing what you were doing and not specifically for the academic
Right.
purpose. So it's
So I had finally finished the dissertation and got my PhD, and but I wasn't really paid to teach until quite a bit later. So I was still doing primarily, but when I started going to India, the psychotherapy practice evaporated because psychotherapy clients don't want you to go away for 6 months at a time. But the Rolfing continued. So I'm a little foggy about what the next item in the history would be.
well, I'd be curious to take a pause a little bit on the on your medical anthropology, the trips to India. What were some of your more interesting findings?
Well, I thought I was going to find a lot of PTSD because most of the Tibetans in northern India were fleeing the Chinese occupation of Tibet. Something like a sixth of the population left. So there were 1 million Tibetan refugees in India. And the Indian government was very welcoming. And there was actually a Tibetan government in exile. There still is in Dharamsala. That's where the Dalai Lama is. And they recreated there are many monastic Tibetan monasteries moved to northern India. And the Dalai Lama sponsored a recreation of the primary medical college in Dharamsala. And eventually, by the time I was there was a network of about 40 Tibetan medical clinics all over India that served not just Tibetans, but it became very popular with Indians because it was regarded as potent because it was from the Himalayas and it was an ancient tradition. So I thought there'd be a lot of PTSD in Darjeeling because Darjeeling and Gangtok they're the two major places refugees would go if coming over the border because they're in far northern. I mean, from Darjeeling, you can see the Himalayas. And from Gangtok, you're already in the foothills. But I didn't find a lot of PTSD. Well, I heard stories about people who would come over and act spaced out and weird, but then they'd say, and after a while they were okay. I think it was because they had a very strong community and because of the religious practices. So I did find when I got into sitting in clinics and in interviewing patients, a lot of depression and anxiety. So that became the topic of my dissertation, is Tibetan medical diagnosis and treatment of depression and anxiety.
You feel like you have any sort of insight or advice that from that perspective for depression and anxiety that it's worth the general American knowing?
Well, the Tibetan threshold for depression and anxiety is much higher than ours. They don't go to see the therapist when they feel bad. They don't go until it gets really so it's interrupting their work or their family life or they have symptoms. So it's a higher threshold. And I got interested at the time also in their understanding of possession disorders. If a disorder involved hallucination or delusions, they would attribute that to demons. And they would send the person to some lamas specialized in exorcism. So people who had chronic cases would go back and forth between the Tibetan doctor for the herbs and the exorcist lama. And in some cases, they'd also add the Western trained psychiatrist, of which there are plenty in India. So there'd be a triangle where they'd go around. And the Tibetan doctor's point was Tibetan medicine understands, it combines the Ayurvedic model with the Chinese model. Ayurvedic model is about the three doshas, wind, bile, and phlegm. The Chinese model is the 5 elements: earth, fire, water, wood, and air. And so they combine those. So one of the ideas about depression and anxiety is there's too much wind. So the Tibetan doctor would try to reduce the wind. And because one of the things that makes people liable to interference of spirits is too much wind. And then they'd go to the exorcists, and then they'd go to the psychiatrist for medication, and they'd go around that cycle.
And how did you see, while you were going back and forth, were you feel between doing Rolfing in Boston and doing this studying in India, did you find any of the practices that you were doing? I know Ida Rolf may or may not approve of this, but was it influencing your Rolfing in any appreciable way?
Not really, because to do Tibetan medicine, you have to study for at least 4 years full time. It's a very elaborate pharmacology. The remedies are like Ayurvedic. They have many, many ingredients. Some of them have 20 or 30 different herbal ingredients. So you have to have a lot of technical knowledge. So I basically learned how to feel the pulses. It's a pulse diagnosis. But I didn't ever try to practice. The Tibetan doctor I studied with most in Darjeeling since then moved to Boston. She's been practicing in Boston for 25 years now. So I see her once a month and we talk. I continue to learn a little bit more. But it's a whole separate system. And I decided, I thought I was going to come back to the US and do clinical trials of Tibetan medicine. But at that time, in 2000, to do a clinical trial of an herbal medicine, you had to for the FDA to let you do that, you had to have a huge pile of background information. You would have botany, biochemistry, toxicology, ecology, all these studies that would cost, probably $200,000. The Tibetans didn't have that kind of money. So the only herbal trials going on were of Ayurvedic and Chinese medicine because those pharmacies had a lot of money. So I couldn't do that. So I eventually got funded to do a clinical trial of structural integration for low back pain.
And when did that start?
When did it start? 2009, ran to 2014.
So why low back pain?
Well, it's the most expensive musculoskeletal disorder. It's very poorly treated, and not well understood. And when I asked the senior Rolfers, like Emmett Hutchins and Peter Melchior, if you could do a research project on a musculoskeletal disorder, what would you pick? And they all said low back pain. It's very prevalent.
So could you speak?
Poorly treated.
Yeah, could you speak a little more about what the clinical trials looked like and what findings there were and where that's at?
I did not do a direct comparison because nobody had ever done a clinical trial of Rolfing, and there was no evidence that it had any effect at all. So they weren't going to let me treat patients just with low back pain. So the study was Rolfing as an adjunct to outpatient rehab, which was the standard of care. So, I recruited people and they all had to enroll in outpatient rehab somewhere in the Boston area. Then I hired 5 Rolfers to do the Rolfing. And half of those people got Rolfing and half didn't. And of course, the half that got Rolfing did better. I published the outcome. There's still the symptomatic outcome I published. I still got data. We did blood work, we did movement, we did balance, we did psychology. I've still got to publish all that data.
What do you find? Were there any surprising findings for you?
There was not an immediate statistically significant change in pain. There was in disability. The Rolfing group did much better. But then the IRB, I don't know if your listeners know what an internal review board is. If you get federal funding, you have to have your study approved and monitored by an IRB. The IRB was worried about Rolfing. So they said, you have to monitor people every 2 weeks. You have to monitor their disability and so I had that data. So when I analyzed that data, the rate of improvement in pain was significantly greater. If you drew the 2 slopes through all the 2-week data, the slope of decreasing pain for the people who got Rolfing was steeper than the slope of decrease for people who didn't get. Rolfing. So that was a good outcome. The only psychological thing that changed was there's a psychological construct called, what's it called? Pain catastrophizing. Because what happens in chronic pain is people get very emotional about it. They get upset about it, and that makes it worse. And so there's an instrument, a widely recognized instrument that measures that. It's called the Tampa Pain Catastrophizing Scale. And it's used a lot. And as people got better in my trial, their pain catastrophizing went down, which you would expect. But there was not that much change in depression or anxiety or anything else. It was a small study. There were only 23 people in each group. It took a lot of effort because this was a K1 grant, which is given to people who are new to clinical research to help them start their careers. It has money for your salary, but no money for anything else. A little money for, not enough money to pay for much else. So I did not have assistants. So I had to do everything myself. Recruit the people, interview the people, informed consent, collect the baseline data. I didn't do the Rolfing because that would have made it less credible. Then they had to pick a Rolfer. I employed 5 in the Boston area. But it was a lot of work. It took me 5 years to do all that stuff.
And if you had the funding, what would be your next steps?
I'd like to do another trial comparing Rolfing directly with something else and doing a bunch of mechanistic measures. I'm not as interested in clinical improvement in symptoms as I am in mechanisms, because it's remarkable how little is known scientifically about the mechanisms, not just of Rolfing, but of manual therapy in general. Like the NIH just funded 3 centers to promote the study of mechanisms of manual therapy.
Okay. And when you do a Wikipedia search, and of structural integration or Rolfing, and I find it frustrating that even though, as someone who's not a Rolfer but a structural integrator, I find it frustrating that Wikipedia defaults to the brand name of Rolfing, not the generic name of structural integration. But in any case, it last time I looked, which hasn't been in a while, they let somewhere in big and bold they talk about it has no scientific backing or something to that effect. And I'm a Blue Cross, I'm an occupational therapist and a Blue Cross Blue Shield provider, and Rolfing, interesting that structural integration isn't, again, is listed explicitly alongside craniosacral and a few other things as like non-scientifically backed therapies that are not covered.
Listed by Medicare.
By Blue Cross Blue Shield.
Somebody should refer them to my study.
If they were more organized and better staffed, I would probably be reaching out to them, but I don't know that I think initially things would fall on deaf ears, but for Blue Cross. And then I don't know what the Wikipedia editing stuff is. I may try to at least dig into the background of that to make sure that your study is being mentioned.
No, it's mentioned, but it said it's not credible because it's published in a journal that has problems with credibility. It's one of the highest rated journals of alternative medicine. It's a complete hatchet job. I spent some months trying to fix it, got to talk to the editorial committee. They wouldn't budge. Anything positive I put in was either deleted or changed to something negative. I told them the reason given for the journal not being credible was, well, there was this letter that complained. All journals have letters that complain. The most prestigious medical journals in the world have letters that complain. It doesn't mean they're not credible journals. So I gave up. And then a few years later, another bunch of Rolfers tried to fix it, and they got the same response. It's just, the story is that the founder of Wikipedia is very, very anti anything alternative medicine. So he tolerates these editorial, each page has an editorial committee, and the committee just won't put anything. I think their page on acupuncture is negative too. And Acupuncture is NIH approved for the study of pain. So it's just a terrible resource for people.
So where do you see the with that public opinion, where do you see the future of structural integration and Rolfing as in the public eye and as where do you see that future?
Oh, it's spreading because it works. There are more and more training institutes and more Rolfers. Some states now, there are a few states that include it in their licensing process. Massachusetts, when they passed a massage ordinance, they explicitly excluded about 10 different kinds of bodywork, including Rolfing. They left it up to towns. So some towns regulate bodywork and some don't in Massachusetts. No, it keeps spreading, and there's more and more. Is slowly accumulating research about it. And there's these centers that are going to fund studies of mechanisms of manual therapy are going to help. Because if you look at research on pain, it's 95, 98% neurology. It's all by neurologists. There's very little understood about soft tissue, fascia. And luckily, the current director of the alternative medicine arm of NIH, I think the current name is the National Center for Complementary and Integrative Medicine. They don't use the word alternative because, of course, there's no alternative to conventional medicine. There's only things that can be added to it. Anyway, Helene Langevin is a brilliant researcher of fascia. So she's promoted a bunch of little projects on soft tissue mechanisms. So I think we'll find out more. And as you know, there's tremendous advances in understanding fascia, but it's just on the edge now, people starting to investigate how fascia changes if you work on it manually. It's still very poorly understood.
And I think I've not been keeping up with the fascial research as much as I would like to admit. But my basic understanding on the fascial research is and especially in terms of the mechanisms, is historically we thought that fascia was being moved from heat and pressure, the process called thixotropy, and we were shifting the muscles around. But then there is, at one of the research conferences, someone stood up and basically said it would take the weight of an elephant to be having the tissue changed to the degree that we're seeing it through that mechanism. And since then, it seems like we've been talking more about the nervous system and the fact that fascia is such a rich sensory organ, and that's
Robert Schlepp's idea, and it's a good idea. But there's the issue of hydration. The hydration of fascia is extremely variable. And the mechanisms of hydration are understood pretty well scientifically. As far back as 1899, Andrew Taylor Still, Philosophy of Osteopathy, his rationale for osteopathy was that what was really needed for health was free movement of fluid through the body. And he was very interested in movement through the soft tissue. And he thought the main obstacle was that the joints got jammed up. So the point of osteopathy originally was facilitating fluid movement through the soft tissue. And Dr. Rolf was really into that idea. And it's a very plausible idea. It's just not easy to research. How do you measure the flow of fluid in a living human being's soft tissue? There are probably on the edge of the techniques to do that. Then there's also the fact that the fibrous content of soft tissue can change rapidly. Well, not instantaneously, but there's something about what happens in the tissue when you lean on it that provokes a change in the ratio of fibers. Some fibers are more elastic than others. So that was another hypothesis of Dr. Rolf's, that the ratio of fibers are changing. The problem there is that doesn't happen instantaneously. The instantaneous change we see is probably because of Robert's idea about tone, but also just hydration. But then there are the cells that create these fibers, fibroblasts. They are mechanoreceptors. They respond to they're chemoreceptors too. They respond to mechanical pressure in their environment and to inflammation and other molecular signals. So there's probably some way that the pressure and the hydration from the Rolfing intervention provokes them to create more elastic fibers. They also can dissolve fibers. They secrete enzymes that can dissolve specific kinds of fibers. So they're probably active in changing. But again, how to measure that? That's just beginning to be possible, I think, with high resolution ultrasound.
So, are you familiar much with what Sharon Wheeler has been doing with scar tissue and the ultrasound before and afters on that?
I've not looked at the ultrasounds, but I'm sure they show that there's less.
Yeah, what Sharon was surprised about, and she was saying that doesn't fit with any of the sort of current theories on how scar tissue is formed. And this is, of course, specifically scar tissue, not
Scar
just other
tissue is
things.
just fascia with more inelastic fibers in it. It's not a separate kind of tissue.
Yeah, I think that her treatment of more surface type scar tissue is different than her more traditional Rolfing treatments.
It's more superficial, yeah.
Is that she was doing ultrasounds before and after, and these surprising instantaneous effect. So I guess I'm curious what we both have witnessed pretty immediate instantaneous changes to tissue, and how do you what do you feel that mechanism is?
The only mechanisms that I have thought of are the two I already talked about. Hydration, and then the fibroblasts being provoked to change the ratio of fibers. I don't know if there's mechanical breakage of the denser fibers. That's also possible.
So it seems like the hydration would be a faster effect, and because then I would imagine that the synthesis, the breaking down of fibers that would be taking place, being dissolved from the fibroblasts, would be a longer process.
Yeah, there might also be mechanical breakage from the pressure of the Rolfer.
Mm-hmm.
If the stuff is really tough, But it's probably some combination of all the above.
Mm-hmm.
That's what I tell Robert. I think it's plausible, the neurological stuff he talks about, but also the fluid stuff and the fibers. They're probably all happening. Doesn't need to be just one mechanism.
Yeah, few things really are just a single mechanism. It's just we like to look at single mechanisms because they're easier to control in a laboratory setting.
Right.
Which sort of brings me a little bit to the challenge with having Rolfing studied is that it's such a holistic, and I know that word gets thrown around so much that I almost hate to use it, but it's such a whole body process you're going through. I mean, we're working with opening up the chest and the feet in back-to-back sessions, and the idea that you're making small changes throughout the whole body that result in more cumulative, lasting change, and what that does for overall well-being and energy levels and all those things. That it was my understanding that Ida Rolf would discourage people from getting too fixated on any given area or symptom.
I don't think she would have discouraged people. I mean, she was a biochemist. She co-authored 16 papers on cell biology when she was at the Rockefeller Institute. So she appreciated focusing on very specific mechanistic issues. But the holistic thing, also, that's important. That's when I did my study, and other people are doing studies. We look at whole body movement. We look at balance. We look at psychology. I don't know if you know what the Valerie Hunt study was.
No, I'm not familiar with that one.
That was in the 70s. It was, I think, the first scientific study of Rolfing. There was a UCLA, I think she was a neurologist, neurophysiologist, Valerie Hunt. And Dr. Rolf, she collaborated with Dr. Rolf on a study where I think 10 people got Rolfing and 10 people got exercise. And then she did EMG, and then she commented on the difference in the EMG patterns. In the 1970s, EMG studies were pre-computer, very primitive compared to what you could do today.
Mm-hmm.
I actually collected EMG data pre-post Rolfing on people's low back muscles, but I haven't analyzed it yet.
So you still got a lot of data from that research that you're still working on.
Yeah. Should be working on. The whole other issue I haven't mentioned is placebo. I was very lucky. When I finished my dissertation, I joined a group. Placebo had been for 100 years or more regarded as, quote unquote, in your head. It was defined as the effect of the patient's belief that they're receiving an efficacious therapy. And nobody much paid any attention to it at all until the 50s. A Harvard Medical School guy named Beecher published some articles about placebo, pointing out how big the effect was, that in many cases it accounted for 30% or more of the patient's improvement. Then in the 90s, one of the first Americans who had gotten a degree in acupuncture in China, Ted Kapchuk, got interested. He got a small grant to do whatever he wanted to do, quote unquote. And he got interested in placebo effects. And he restarted that whole field, which is now a huge field, placebo studies. There are labs that do nothing but study the placebo effect. There's reviews of just what happens in the brain with a placebo effect. It's a major thing now. And the point of it is not to discount it, but to show that it's not just in your mind, it's a physiological effect. And it's a component of almost all therapeutic interventions. So the point is not to dismiss it. The point is to amplify it so the patient gets more benefit. So I was part of that group for a while. That group is sort of, it's about 20 years old now. So it's a bona fide scientific field now. People do graduate degrees in placebo studies, and they have careers in placebo studies. But there's very little known about the placebo component of manual therapies, which is certainly there, and doesn't mean there's also not an objective effect. The part that our placebo group at Harvard studied, our outcomes showed that if you had a richer communication with your therapist, for some disorders, you would get a much bigger placebo effect than if you had a minimal relationship with your therapist. So relationship with therapy, there are all kinds of factors that change it. The setting, the patient's expectation, the communication with the therapist. So it's useful stuff to know.
And it's my understanding that surgery is a very major placebo. Not that there aren't other obvious effects, but and I know low back surgery in particular, certain types have been sort of presented as pretty close to on par with placebo, and I'm not quite sure how you do a placebo low back surgery, but versus a real low back surgery.
I don't either. There are hardly ever placebo controls in surgery trials, because the biomedical world just assumes that, well, surgery is objective. But before that attitude, there were a few trials of surgeries that at the time were thought to have an objective effect. It turned out the placebo effect was almost the same. If you cut the person, sewed them up, and told them they'd had the procedure, it was about the same effect as if you actually did the procedure.
Which isn't to say it wasn't a significant effect, too.
Oh, yeah.
But just like what you were saying with manual therapy, that there is that we shouldn't just be dismissing placebo effect.
Oh, no. We should be learning how to maximize it.
Yeah, I was listening to, I can't remember what the name of the study was, but Parkinson's, where someone having the electrodes for the deep brain stimulation implanted, and there was a button they'd push when they were having Parkinson's tremors and other symptoms, and they set it so that sometimes the button actually did the electrical shock to the brain and sometimes it didn't.
Yeah.
And at least initially, when it didn't, it had like 90 to 100% the same effectiveness as if it had actually shocked the brain.
Yeah.
Which is like just amazing to say something is all in your head as almost a pejorative and a like dismissive is it seems silly when we have such a massive medicine cabinet in our head and an ability to literally shock our own brains.
There now are people who just study what happens in the brain with placebo phenomenon.
Well, thank you so much for the conversation today. I really appreciated you taking the time.
Oh, it's interesting. Sorry it took so long to arrange. You're a good interviewer, Erving.
Thank you. I hope you enjoyed this episode with our conversations about Rolfing, placebo, and Tibetan medicine. If so, you can tune in next week and get a little extra episode where we'll be talking about Rolfing and its relationship to transcendental meditation, specifically the practice of Eric Jacobson's. Again, I hope you enjoyed Resilience Radio. The music was brought to you by Aaron Marcus with their tune Some Biological Process. You can check out the show notes for full credits on that. You've been listening to Resilience Radio. Take care.